let Tracy begin.
Malika, can you hear me okay? Is my sound okay?
Yes, we can hear you.
Okay, perfect. Hi, everyone. As Malika said, my name is Tracy Esquivel, and I represent the California Diabetes and Pregnancy Program Sweet Success. And the purpose of our program is to improve maternal and fetal birth outcomes through promotion of health education and disease prevention. The CDAP Sweet Success Resource and Training Center, what I represent, and what Dr. Sandy Ramos and many others represent, we train and support Sweet Success affiliates throughout the state of California who provide healthcare services to pregnant women who have pre-existing or gestational diabetes during their pregnancy. And we do this by using many of our resources. One of them is the CDAP Sweet Success Guidelines for Care, which is available on our website and might prove useful to you who are on the call today. This is on our website, www.cdapsweetsuccess.org, and its Guidelines for Care is in the top banner there. And it's a larger document, medical guideline. It's about 300 pages, a little bit less, and it's not just talking about postpartum care like we are delving into today, but it also covers everything before, during, and after pregnancy that's been complicated with diabetes, related to diabetes, excuse me. So breastfeeding, medical nutrition therapy, medical management of type 1, type 2, and gestational diabetes is covered, along with exercise and cultural competency. That is our larger document. We also have free patient and provider materials and resources that you might find useful to you. And those are also available on our website, like I already mentioned, under patient materials and resources in that top banner. We also have these, we're using, like Malika mentioned, we're using this webinar as a training module, and currently we have 190 active affiliate organizations or sites throughout the state of California. And this webinar will be used as a training module that is a requirement for CDAP Sweet Success providers. And we're excited that it's going to be useful to you as well, as Malika has told me that you all have expressed interest to learn more about postpartum care and testing following pregnancy with gestational diabetes. Now I'd like to present to you our speaker. Dr. Sandy Ramos received her medical degree from the College of Medicine at the University of California, Irvine. She went on to complete her residency in obstetrics and gynecology from Kaiser Permanente, San Francisco. Dr. Ramos earned her fellowship in maternal fetal medicine at the University of California, San Diego School of Medicine. She is board certified in obstetrics and gynecology and maternal and fetal medicine. Dr. Ramos is currently a clinical professor at the University of California, San Diego in obstetrics, gynecology, and reproductive sciences. She also is the director for the UCSD Diabetes and Pregnancy Program and collaborates with CDAP Sweet Success extensively, as she is part of our stakeholder group. She helps us update our guidelines for care, that resource I mentioned to you earlier, and she presents for us on many topics relating to diabetes and pregnancy. So Dr. Ramos, thank you so much for being with us here today, and when you are ready, the presentation floor is yours.
Thank you, Tracy, for that introduction. And thank you, everyone, for your attention for the next few minutes as we discuss something that's super important in the care of women after pregnancy. So sorry, I'm trying to move my slides forward. Can you see them okay?
I see your, I think we need to put it in presentation mode. If you say use slideshow mode, because we can see all the slides, like little ones at the bottom.
Okay, I do have it in presentation mode. Are you, so you're only able to see the bottom, or are you able to see the big slide?
I can see, I see the big slide and then the next slide, but are you using two screens or one?
I'm using one.
Okay, so we see the black, around the black portion as well. I think it needs to be in
Not in presenter mode, but in slideshow mode.
Perfect.
Yeah, yeah.
Is that better?
Perfect.
Okay.
Perfect.
Yeah.
Okay, sorry about that. Okay, so I wanted to just let everybody know that I have Nothing to disclose with regards to this is an outline of my talk. We're going to be talking about immediate postpartum care following gestational diabetes, why it's important to know some of the long-term complications of gestational diabetes on a mother's future health. We're going to talk about the different prevention modalities for preventing some of these long-term complications, including type 2 diabetes. And specifically, we're going to be talking about the impact of breastfeeding, lifestyle modification, and then we're going to touch on the use of metformin. We're also going to talk not only about gestational diabetes, but postpartum care in pre-gestational diabetics, and then lastly, contraception. So what do we need to know after a woman delivers and her pregnancy was complicated by gestational diabetes? Initially, I'm going to start talking about the immediate things that we need to think about, and then we'll go through some of the later interventions. Unfortunately, there's not much guidance in regards to what to do immediately after a woman delivers whose pregnancy was complicated by gestational diabetes. I've recently looked at American Diabetes Association as well as ACOG, and they're quite vague in what they recommend. However, luckily we have the California Diabetes and Pregnancy Program, which offers us some guidelines for what we can do. An immediate postpartum is about 1 to 3 days after delivery, and they break it down by gestational diabetes managed with diet and exercise alone versus those who required medication during pregnancy. What they recommend immediately postpartum is going back to a healthy diet and not continuing a carb-limited diet necessarily, because this will allow us to evaluate what the patient's glucose values are on a regular diet, assuming that this is what they're going to go back to when they go home. We generally recommend at least one fasting and 1 hour after meal prior to discharge in mothers who only required diet and exercise for control of their diabetes. In mothers who required medications to control their diabetes, we do recommend at least for 24 hours checking a fasting blood glucose and 1 hour after each meal. And again, we don't know exactly if this is the perfect algorithm, but it's something that we recommend to identify hyperglycemia after delivery. Actually, I have a resident currently working on a project to evaluate which is how many times do we really need medications after delivery when a woman has gestational diabetes that required medication during pregnancy. Now, in terms of addressing the hyperglycemia after delivery, it's very rare that a woman who had excellent control on just diet and exercise requires medication after delivery. In those who did require insulin, for example, prior to delivery, a percentage of those moms may need medication, and generally it's recommended that metformin be utilized after delivery to achieve that normal glycemia. And I will define normal glycemia for you later in the presentation. What I want to come back to, and we will come back to this time and time again, is the importance of having postpartum screening. It's recommended that this occurs sometime between 5 weeks to 12 weeks postpartum. As you know, most of us see our patients about 6 weeks postpartum. And really the gold standard for postpartum screening after having a pregnancy complicated by gestational diabetes is a 75-gram fasting OGTT. And really what we're interested in is the different values, and we'll go through them. But diagnostic criteria for type 2 diabetes entails looking at the 2-hour value. And again, we'll go through those cutoffs later in the presentation. Many people have asked me whether or not an A1C is an appropriate modality to screen with. Unfortunately, the A1C, especially at 6 weeks postpartum, may not be accurate for diagnosis of either prediabetes or type 2 diabetes because there's some changes that occur immediately postpartum. We know that with breastfeeding, there's marked weight loss, for example. And number 2, there can be anemia that persists after delivery, particularly after a C-section. Both of these factors can lower the A1C and make it less useful in terms of diagnosis. However, we do acknowledge that there is a lot of barriers to performing a fasting 75-gram OGTT, and therefore there is a consideration for doing an A1C at or after 3 months when some of those rapid changes and hopefully the anemia have recovered and makes it more of an accurate test. So that is an option in patients that you feel will not be able to comply with postpartum screening. Now, why is postpartum screening so important? Well, let's talk about some of the long-term maternal consequences of gestational diabetes. In other talks, I have gone through what are the long-term consequences for the fetus, but here we're going to focus on the maternal consequences. This was an interesting study done on approximately 50 or so GDM patients and 50 control patients. And they followed this group for 5 to 6 years after delivery. And what they look at were different parameters of metabolism, including hypertension or systolic and diastolic blood pressure, blood glucose levels, cholesterol, triglycerides, and total cholesterol. And then they compared these values between the control group and those mothers that had gestational diabetes. And they noted that systolic blood pressure was higher in the mothers who had gestational diabetes. Blood glucose values were also higher, as were LDL, total triglyceride, and total cholesterol. Again, this is demonstrating that there's some long-lasting effects on metabolism after being diagnosed with gestational diabetes in pregnancy. Interestingly enough, when we looked at the data closely, the average BMI for these mothers was 25. This study was done in 1996. So as you can imagine, now we have more of an obese population, and it may be that these differences are actually more pronounced. They then followed women longitudinally for 11 years, and they were looking at blood pressure, specifically systolic hypertension, in the controls versus the GDM cohort. And what they found was that at each time point, 4 years through 11 years, you can see that there was a higher systolic blood pressure in the mothers who had gestational diabetes as compared to controls. And the rate of systolic hypertension was 30% in gestational diabetes mothers as compared to controls, which was approximately about 14%. So there are long-lasting repercussions to being diagnosed with gestational diabetes. When they looked at the cohort overall, the rate of type 2 diabetes in the GDM cohort was about 13% compared to 4% in controls. And what we call metabolic syndrome, which encompasses obesity, hypercholesterolemia, hypertension, etc., it was about 27% in the GDM cohort versus 8% in controls. This is a study focusing on looking at all the different studies that have been done looking at this issue of metabolic syndrome following gestational diabetes pregnancies. And there's a bunch of studies listed here. You don't have to worry about that. I just want you to focus on the number down here. An odds ratio is akin to the risk of a mother developing metabolic syndrome. And when you pull all these different studies together, the odds ratio for developing metabolic syndrome is about 4, which is pretty significant. So when do these mothers develop type 2 diabetes? This was a study looking at specifically that question. And they looked at different ethnic groups, including Hispanics and Native Americans, as well as a mixed cohort. And what they found was in the first 5 years is the highest risk time of developing type 2 diabetes following gestational diabetes and pregnancy. And that increases up to about 8 to 10 years. And then after 10 years, it levels out. So if we're going to employ interventions to prevent type 2 diabetes, we need to focus on these first 5 years after delivery. So to summarize, gestational diabetes increases the risk of metabolic syndrome by about 4-fold. It increases the risk of type 2 diabetes by about 4 to 7-fold. And almost 50% of women will develop type 2 diabetes within 8 years following delivery. So how do we modify these risks? Before we get into modification, I wanted to go through some diagnostic criteria. In 2010, The American Diabetes Association recommended the following definitions, and these are important for us to know as we consider postpartum screening in these women. Prediabetes is defined as an A1C of 5.7 to 6.4, and although endocrinologists will often look at me like 5.7 is not very high, when you look at the cumulative risk of developing type 2 diabetes, it's actually quite high with an A1C in this range. They also defined what they called isolated impaired fasting glucose, which is a fasting glucose of anywhere from 100 to 125, and then impaired glucose tolerance, which is a 2-hour plasma glucose value on a fasting 75 gram of GTT of 140 to 199. They also reinforced the diagnosis of type 2 diabetes, which would be an A1C of greater than or equal to 6.5%, having a 2-hour value of greater than 200 on that fasting 75 gram OGTT, and a fasting blood glucose of greater than 126. Any of these are criteria for diagnosis of type 2 diabetes. And so again, coming back to postpartum screening, they recommend 75 gram fasting OGTT at 5 to 12 weeks postpartum, and to look at all the individual cutoffs. And if a mother meets any of the cutoffs for either overt type 2 diabetes, she should be referred to the appropriate physicians for care, or if they have impaired glucose tolerance or impaired fasting glucose values, they should be referred for further counseling. And testing really should occur every 1 to 3 years based on risk factors. And the way to test for overt type 2 diabetes, again, is a fasting, an A1C, or a 75 gram 2-hour OGTT. Breastfeeding is a powerful tool to help us prevent the onset of type 2 diabetes. As you know, pregnancy is characterized by insulin resistance and also elevations in fasting triglycerides, not to mention weight gain. All of these predispose to further development of the conditions we've discussed before. However, breastfeeding is actually the converse. It's characterized by improved insulin sensitivity, and women actually utilize about 50 grams of glucose for breastfeeding in 24 hours and utilize about 500 or more calories per day for breastfeeding. It's also characterized by decrease in lipids, so there's a higher rate in actually the good cholesterol, HDL, with breastfeeding. It allows for mobilization of fat stores that were accrued during pregnancy, and obviously weight loss. And all of this leads to a lower rate of metabolic syndrome, particularly in mothers with gestational diabetes. Again, this is another study that was performed to look at the effect of duration of breastfeeding and the effect on the development of metabolic syndrome. A hazard ratio is sort of like, what is the risk of a mother developing metabolic syndrome here on the y-axis, and on the x-axis is duration of lactation. And I want you to just focus on the trend. Notice that there is a dose response, meaning that the higher the number of months that a mother breastfeeds, the lower the rate of metabolic syndrome in that mother. This is really powerful, and again, just breastfeeding over 9 months seems to have the best effect on modifying the risk of future development of metabolic syndrome. But breastfeeding is not only good for mothers, as you know, it's excellent for neonates, but what effect does it have in regards to the prevalence of childhood obesity? This was a study that looked at the effect of breastfeeding, and in this study, breastfeeding was only followed for women who breastfeed for more than 3 months here in the black, 1 to 3 months in the gray, and no breastfeeding in the white. And they looked at a total cohort of women and then looked at the overall childhood obesity rate. And as you can see, I think I had it backwards. Sorry about that. The black is never breastfed. The gray is breastfed for 1 to 3 months, and the white is breastfed for more than 3 months. And as you can see, with breastfeeding, when we look at the total cohort, the rate of childhood obesity is lowered with breastfeeding with as little as 3 months. Now, when you look at women who were obese, so these are the mothers who are obese, because there's always, as you know, an independent relationship between maternal obesity and childhood obesity. What you note is that the effect is even higher. The rate of childhood obesity in children or offspring born to mothers who are obese was pretty high, about 56%. But with breastfeeding for 3 months, the rate of obesity went down to 31%. So it's even particularly more important to counsel our patients who had GDM in pregnancy about the effects of breastfeeding and the effects of breastfeeding not only on her health, but that of her offspring. Now, what do we know about prevention of the onset of type 2 diabetes in adults? There have been 3 pretty large studies that have been quoted over and over in the literature in regards to prevention of the onset of type 2 diabetes. The first one was done in China, or not the first one I'm going to discuss, was performed in China in 2008 and published in the Lancet. And what they did was they followed people for approximately 20 years. And what they did was lifestyle modification in people who had impaired glucose tolerance. And with lifestyle modification, they noted a 46% reduction in the onset of type 2 diabetes. There was a Finnish study that very similarly followed people for 7 years. And they looked at the reduction of type 2 diabetes with lifestyle modification. It was a little bit different than the Chinese trial. Nevertheless, they saw a 43% reduction. So interventions do play a role. And lastly, the one that we will reference all the time is the Diabetes Prevention Program, which was done here in the United States and published in 2009. And they followed participants for 10 years, and they saw a 34% reduction in the onset of type 2 diabetes with lifestyle modification. The DPP trial also did an interesting sub-analysis where they looked at women who had gestational diabetes in pregnancy and then compared them to women who did not have gestational diabetes in pregnancy and looked at the reduction of type 2 diabetes in a group that was randomized to either metformin or intensive lifestyle modification. And here's the control for baseline. And you can see again and again that in the placebo group, the rate of development of type 2 diabetes was higher if you had GDM versus no GDM. Then they looked further at randomization to either intensive lifestyle modification or metformin, and how did that compare to placebo? As you can see, in mothers who had gestational diabetes, metformin lowered the rate of type 2 diabetes by half, but so did intensive lifestyle modification. So the reduction was about 53% for intensive lifestyle modification, and then for metformin, it was 50%. And the number needed to treat, that means how many people do we need to offer this intervention to see a reduction, was only 5.3 for intensive lifestyle modification and 6.1 for metformin. So these are powerful interventions in the prevention of type 2 diabetes in this group of women. What's also important to know is that intensive lifestyle modification actually had a longer effect than metformin. So what is meant by intensive lifestyle modification? Well, the American Diabetes Association has detailed what we need to do in order to achieve this, and that's obviously exercise and healthy diet intervention. And what do we need to achieve is 7% loss of initial body weight. And they also recommend 150 minutes of moderate intensity physical activity during the week. And that's what they call intensive lifestyle modification that we should recommend to our patients. American Diabetes Association also recommends at least annual monitoring for the development of type 2 diabetes in people who have prediabetes based on any of the criteria that you and I discussed earlier in the presentation. That we should also employ any technology-assisted diabetes prevention interventions that may exist, and that this should also be covered by third-party payers, because prevention with intensive behavioral lifestyle interventions does have a major effect in the prevention of type 2 diabetes. What about metformin? The American Diabetes Association recommends metformin for the prevention, not only treatment of type 2 diabetes. If a patient has prediabetes, and especially if they have obesity with a BMI of greater than 35, younger patients aged less than 60, and women with prior GDM. So women who are identified to fall in these categories who have prediabetes on their postpartum screening, who are obese, should be offered metformin for the prevention of type 2 diabetes. Now, there's some issues with long-term use of metformin, including vitamin B12 deficiency. So patients that are offered metformin, as opposed to lifestyle intervention, should have periodic measurements of vitamin B12 levels. So coming back again to postpartum screening. Again, we recommend postpartum screening at 5 to 12 weeks with a 75-gram 2-hour DTT, and then testing should occur every 1 to 3 years based on risk factors. Unfortunately, we're really poor at postpartum screening. Only about 23 to 61% are screened postpartum. And this is very much in line with the number of women that actually show up for postpartum visits in general. So what can we do? Well, we need to figure out what the barriers are in our population to postpartum screening. So there's an issue with a lack of understanding and awareness of the risk of type 2 diabetes after a woman is diagnosed with GDM in pregnancy. So when I counsel my patients, when they first come into my clinic with gestational diabetes, we talk about the short-term implications for the baby and long-term implications later on, including the risk of childhood obesity. And then we talk about the short-term maternal complications of gestational diabetes and then the long-term consequences. So we even start talking about it right at diagnosis. We also talk about socioeconomic and ethnic factors that may contribute to barriers to postpartum testing, including difficulty with travel. Some of my patients have a difficult time coming to clinic visits. And of course, lack of family support. Now they have a brand new baby and they can't make time to come in for a postpartum visit or even to undergo their screening. They also are worried about the discomfort of the test, having to come in, as you can imagine, postpartum, breastfeeding, NPO, and then having to wait to have their glucose challenge test can be an uncomfortable procedure. And obviously there's barriers in the healthcare system. There's poor bridging between antepartum to postpartum care, and actually ACOG has an initiative to try to improve that transition. And there's also poor communication between OB and primary care physicians. And this is something I struggle with in my own practice in trying to improve the communication between primary obstetricians and primary care physicians after delivery. There's several strategies that we can employ. Patient reminders are important. At our clinic, we actually do all of these. We call our patients and tell them to remind them that they need to come in fasting for their postpartum visit, so that way they can complete their 2-hour DTT. We email them or send them mail reminders as well. We also provide physician reminders to remind them that the patient did indeed have GDM, because many times in their postpartum visit, they have a list of issues to go through, including mood disorders, perhaps a diagnosis of hypertension, not to mention wound issues if they had a C-section, breastfeeding problems, etc. And on top of that, they have to remind the patient to do a 2-hour DTT, and it's good to remind physicians to put in the orders ahead of time. We also provide verbal counseling and education to our patients, as I mentioned earlier, but having this in written format may also be helpful. Also, having flexible appointment times is important, especially for new mothers. And people are studying the option of telemedicine as a potential intervention to improve postpartum screening in mothers with GDM. As I mentioned earlier, ACOG has really been focused on this, what they call the 4th trimester of pregnancy, which is really the postpartum period in mothers. Because what they've noticed is that what happens in pregnancy often carries over to a mother's long-term risk of cardiovascular conditions, type 2 diabetes, and can impact not only their child's health, but also their future health. And knowledge of these associations for providers allows us to then improve the care of these women so that hopefully we can optimize their health care in the postpartum period and improve subsequent pregnancy outcomes. Because if we can address some of these issues ahead of time, we can prevent complications later on. And so I want to just teach you about this postpartum toolkit. I recommend that you go online and look over this toolkit because it has some important practical recommendations for postpartum care in these women. And this includes women who had gestational diabetes as well as gestational hypertension and preeclampsia. So what do we do in terms of postpartum care in pre-gestational diabetes? So moving on from gestational diabetes. What we know is that pregnancy hormone levels drop very, very quickly after delivery with removal of that placenta. And there's what we call a honeymoon period, where the glucose values drop precipitously due to a drop in insulin resistance, such that within the first 3 to 4 days, there's a drop of about 30%. And our usual rule of thumb in our clinic is that when we're planning on insulin doses after delivery, we generally think about 30% of pre-delivery insulin doses or about 60% of pre-pregnant insulin doses are required immediately postpartum. And we have seen this effect in type 1 diabetes patients in our clinic. Even well-controlled type 1 diabetes patients have a tremendous drop in their insulin requirements postpartum. There's obviously patient autonomy with supervision and documentation of their glucose values, although we do recommend that they continue to do self-glucose monitoring, particularly our type 2 diabetes patients, as many of our type 1 diabetes patients are now on continuous glucose monitors. And we tell them that we aim to keep their blood glucose at less than 180 and greater than 70 milligrams, and we use a sliding scale correction for boluses if need be. We talk a lot about the effects of breastfeeding on their glucose values. Breastfeeding tends to suppress estrogen, as we talked about earlier, and can lead to weight loss and higher utilization of glucose. So that leads to a higher insulin sensitivity, actually, in women with pre-gestational diabetes. And it's often common to have post-nursing hypoglycemia. And this occurs not during breastfeeding, but when a mom is refilling her breast with breast milk, and that's usually the time when she's burping her baby. So what I usually tell mothers is, as you're nursing your mom, you're also having a snack because that's when you're prone to developing hypoglycemia. Postpartum, we also reach out to our patients every 1 to 2 weeks after delivery, and we encourage them to try to follow up with us weekly. This is easier for those patients on continuous glucose monitoring, as we can just have them import their data. With type 2 diabetes patients, it's a little bit more complicated, but we try to encourage adherence. And obviously, we see them at their 6-week postpartum visit and ask them, how is your medication dosing going? Are you having any hyper or hypoglycemia? And then we also obtain an A1C. Again, we know the limitations of A1C in diagnosing type 2 diabetes after a pregnancy complicated by GDM, but we do recommend an A1C at 6 weeks postpartum in mothers with pregestational diabetes to figure out where they're at in that postpartum period and whether we need to address anything in regards to control. And then we tell them to follow up with their endocrinologist. We review healthy eating and weight loss. We continue to reinforce a healthy diet. We recommend normalizing their BMI, and of course, breastfeeding plays an important role in this. And we also tell them to stay active, walking, again, 30 to 60 minutes per day or the 150 minutes per week, as is recommended by by the American Diabetes Association and ACOG. In terms of medications utilized for diabetic control, as you know, insulin is safe to use with breastfeeding, but so are glyburide and metformin. They're considered to be safe with breastfeeding. And actually, many patients with type 2 diabetes, I stop their insulin and start them on metformin postpartum. We aim to keep their A1C at less than 6% initially postpartum. Again, this is important for wound healing, particularly in mothers who had lacerations at delivery or had a C-section for delivery. As I mentioned before, we recommend referral back to the primary care doctor or the endocrinologist after seeing me at their 6-week postpartum visit. And then we reinforce the importance of preconception control to prevent complications in subsequent pregnancies, including birth defects and adverse pregnancy outcomes. And so I talk to them about this even at their postpartum visit so that they can come back and see me for preconception counseling as they plan for their next pregnancy. This is what the American Diabetes Association recommends outside of pregnancy in regards to glucose control. So we're talking beyond the 6-week postpartum visit. They recommend an A1C of less than 7, a preprandial glucose value of 80 to 130, and a peak postprandial value after eating of less than 180. And this is what I teach my patients after their 6-week postpartum visit, that this is their goals that they should adhere to. Now, no postpartum talk is complete without talking about contraception and optimal pregnancy spacing. And again, this is an area of debate, and we're still learning a lot about what is truly optimal pregnancy spacing. But generally, we talk about 18 months between deliveries as being an optimal time, and to avoid short interpregnancy intervals of less than 6 months or so. Why? Because we know that short intervals between pregnancies are associated with adverse pregnancy outcomes, including a higher rate of preterm birth and growth restriction. And we don't know the exact mechanism, but we do think that with short interval of pregnancy, a mother has not had time to normalize her metabolism following that initial pregnancy. And so therefore, it's important to discuss with mothers this optimal pregnancy spacing. And in order to achieve that, we need to know about contraception. I want to refer you to the World Health Organization because they have a toolkit for contraception options in mothers, where you are able to dial in specific medical complications that a mother may have and look at whether or not they recommend that method of contraception. And this is what they have, is they have categories 1 through 4 in regards to the method of contraception. And basically, I just want you to know that category 1 to 2 is that you can use these methods generally with good clinical judgment, of course. And then 3 and 4, generally 3 is a method of contraception that's not usually recommended unless there's some other underlying issue. And 4, the method should not be utilized. So when we look at gestational diabetes, the World Health Organization actually says that there's no contraindication to any type of contraception. So all types of contraception are really category 1 or 2. Now, combined oral contraceptions, there's conflicting data with breastfeeding because of the estrogen component, which may lower breast milk production. And so in general, we tend to avoid that unless it's a very high-risk patient. And in regards to progestin-only contraception, there was early concerns for the fact that maybe it allowed for a faster progression to the development of type 2 diabetes in women who had gestational diabetes in pregnancy. However, this data has not been consistent. And when you think about the risk of a short interval pregnancy in a mother who had GDM, probably the risks of that outweigh any risk of progression to type 2 diabetes with progestin-only contraception. So I utilize it in our patients. And this includes contraceptive pills as well as the Nexplanon contraception. What about pregestational diabetes? Again, we have the same issues with combined oral contraceptions in regards to the estrogen component. However, not only that, you have to also be worried about other comorbidities. And so they recommend looking at the severity of these comorbidities. And this is where the World Health Organization toolkit really helps us, because you can look at cardiovascular, nephropathy, etc. But in general, it's considered that combined oral contraception is a category 2 contraceptive. And then progesterone contraception only is also category 2. And there's little evidence actually that progesterone only contraception has long-term effects on diabetes control or on lipid profiles in these mothers with pregestational diabetes. In summary, we advise patients on adequate contraception because the risk of becoming pregnant with short interval pregnancies or with poor pregestational diabetes control is probably higher than the risk of using a contraceptive method. So I want to thank you for all your attention, and I'm happy to take any questions at this point.
Thank you so much, Dr. Ramos. I will filter the questions as people type into the chat box. So feel free to type in some questions if you do have them, and I will ask them to you.
We'll give people a few minutes if you want to type anything into the chat box.
I noticed Catalina mentioned, will everyone have access to the slides for a quick review? I will definitely send them to Malika, and she could send them to everyone on the call. Okay, looks like we have another question. Dr. Ramos, is it better to do an A1C at 3 months rather than 6 weeks postpartum?
It is better to do it at 3 months rather than 6 weeks postpartum because, as I mentioned, some of the changes that occur postpartum that can be quite dramatic in terms of weight loss and anemia, et cetera, are more or less stabilized by that point. However, in my experience, it can be a little challenging to keep track of patients and know when to call them in for that, whereas their 6-week postpartum visit is a nice time to order a 2-hour DTT.
Fantastic. I did get a private message about, do you mind elaborating a little bit more about the controversy between the 18-month interval between pregnancies, and is it okay to do a little bit longer, a little bit shorter? Obviously, is 18 the middle ground?
Yeah, it appears that 18 months is sort of the middle ground. There's been several studies, and there's been the problem is that the way they define short interval of pregnancy may differ, and whether or not they use between the beginning of pregnancy to the next pregnancy versus delivery and the next pregnancy. So the way they define it is a little different, and so it's hard to know for sure which is the ideal time. But I think as a rule of thumb, I recommend my patients wait at least 18 months to try to avoid some of those issues, since we don't know for sure what the optimal time is.
Got it. Thank you. Another question is, and I know there's a lot of studies about this, does a baby born from a mother who's experienced gestational diabetes in her pregnancy have a greater chance to develop diabetes as an adult?
Yes, and there's a lot of studies being, a lot of epidemiologic studies in the past that showed that association, and then current studies are looking at that effect. Obviously, maternal obesity plays a role in the future development of obesity and type 2 diabetes in the offspring, but there is a relationship. What the exact relationship is still being studied, but we do know that there's a relationship. And so that's why I recommend to my patients to normalize their glucose during pregnancy to try to avoid the development of macrosomia.
Thank you. Catalina, I think, had another question related to her previous question, and let me know, Catalina, if I got it wrong. But in terms of, she asked about the A1C at 3 months versus 6 weeks postpartum, but for the 2-hour OGTT, is it okay to do it at 3 months versus the 6 weeks postpartum? Or I know you touched about this in your presentation as well.
Yes. I mean, honestly, any screening is better than no screening in my book. So I individualize. If a patient's looking at me, like, I have 5 kids at home, I just had a pregnancy complicated by GDM where I needed tons of insulin, I will recommend that that patient have an A1C right then and there just to kind of see, and then have them follow up with their primary care doctor shortly thereafter to have a 2-hour TTT or an A1C, whatever is more feasible for her to accomplish. So we have to individualize our care. I'd rather patients be screened than not screened, but I just want you to know that there's limitations to getting an A1C at 6 weeks postpartum. And if it's negative, then you can't feel wholly reassured with that.
Mhm.
So a lot of our welcome baby nurses may have seen clients with gestational diabetes, so I invite you to think about what kinds of challenges you've seen with those clients. So if you can think about that and share what you may have experienced, that would be useful, I think.
I'm also curious, this is Tracy again, to hear from the group. A lot of our CDAP Food Success affiliates share that the client, after coming back, or if they don't come back and they just talk over the phone, if they have telemedicine, that there's an issue with understanding disease progression, and that many believe that once they deliver, they don't have diabetes anymore and there's nothing to worry. So I'm curious to know if others have experienced that as well, that maybe the client doesn't understand that there is other risks of converting to type 2 diabetes, and like Dr. Ramos has mentioned, increase in metabolic syndrome, and if any of you have heard of something similar in your experience with home visiting. Anyway, it looks like someone mentioned that a lot of mothers do not get the 6 weeks postpartum OGTT. I could see that. I forget what you said in your presentation, Dr. Ramos. Didn't you say 21 or 23 to some 60% don't come back postpartum?
Yeah, about 23 to 61% are screened. So that means that there's about, the converse is like 40% to 75% are not screened. So it's quite low.
Yeah.
I almost wish we had a test that we could take to them at home. Since you guys do home visits, wouldn't that be amazing if we could have a way to do something at home that would prompt then a visit either with primary care or their obstetrician?
That would be amazing, I think.
Give it another minute, but if there's no more questions, I think we've gotten a lot of really great information that I think will be really useful in our home visits. I have a question that was emailed to me. What I've seen from Ileana, what I've seen is most moms that have had gestational diabetes have no idea what to do postpartum. No discharge instructions telling them whether they stop their meds, continue glucose checks, etc.
Yeah, that's very true. I sometimes forget that I'm so lucky with the program that we have, because we have our diabetic educators that do the counseling before they deliver. In general, we talk to them at around 36 to 39 weeks about what to do after delivery, sort of as their postpartum counseling. For you guys, what I want you guys to know is that the patient should stop medications after delivery unless told to continue by their obstetrician, and to a healthy diet, but they don't have to be on a carb limited diet, especially with breastfeeding. And when cleared by the physicians, to go back to activity, exercise. And exercise means walking for many of our patients. It's challenging because I don't know, how they screen for gestational diabetes to begin with, or how they diagnose for gestational diabetes at your clinics. But I think in general, most women that require medications in pregnancy don't require the medications after delivery. So that's something to keep in mind. Also, many women will continue to test their blood sugars. I've noticed that too, and I usually tell them to stop, that they will be tested in the hospital, and if all is normal, they should just stop monitoring their blood sugars. Can I ask a question? What delivery hospitals are you guys mostly involved with?
Sorry, you want to know which hospitals we work with?
Yes, exactly.
So we have 14 hospitals around LA County. So we have Antelope Valley Hospital up in Lancaster.
I know Antelope Valley.
Yep, and then we go all the way down to Long Beach. We have Miller's Children's and St. Mary's, and then we go all the way out to the San Gabriel Valley with now Emanate Health, but previously Citrus Valley Health Partners. Our senior communication specialist has just actually put our 14 Welcome Baby Hospitals as a link in the chat box if you wanted to take a look at where we have our home visiting sites, if you'd like to look.
Okay. For some reason, I'm not able to see the chat box, but you can email me that information.
Sure, of course. It's in. It should be in the dashboard. There should be a chat drop down.
Oh, there it is. Okay.
We had a comment from Jody Rosen saying that we hear that their blood sugars are good after delivery and then there's very little follow-up.
Yeah, and I think that's what ACOG's goal has been recently with describing what the 4th trimester of pregnancy is, talking about that postpartum period and education, and having OBGYNs and those who provide care for women after delivery be aware that there's things that we can address specifically if a mother had gestational diabetes or hypertension complicating their pregnancies. Because they've realized that there is this void in terms of we're all so focused on taking care of a woman during pregnancy. We're so focused on having her have a healthy delivery that we forget afterwards about the mother in the postpartum period. And so these are important things to address.
Catalina mentioned an educational information sheet she has from ACOG that she takes to patients who have gestational diabetes. We'll also try to get you some other handouts that you can take if these are clients that who need that information.
I think that's great. That's good to have written information as well as verbal information.
Okay. Any final questions or comments that people want to ask Dr. Ramos? Okay, we have a question from, or a comment from Tanya from MLK Centinela. Some of our moms do not have primary doctors and are on restricted Medi-Cal insurance covering pregnancy-related issues, and hence we try to get them to see doctors.
I know that's something I struggle with as well, that many times moms will lose the health insurance coverage after a delivery, and I particularly worry about the moms who had gestational diabetes and maybe hypertensive conditions. There's nothing we can do to really solve that. There's some amazing community clinics, as you know, and I would recommend that you look into those resources for your patients. We have a list of community clinics that'll take uninsured patients for very low costs that we hand out to our patients.
Okay. We have some thanks and you know, great to see the latest research and practical info on this important issue. We will be posting. This will be on the website for Sweet Success, and we will be posting it on our blog with some additional resources that may be useful in your home visits. And I just really want to thank Dr. Ramos and Tracy for making it happen. And we will send you the notes and the follow-up link, and hope you all have a great rest of your day, and we will talk to you next time.
And I just want to say I'm really impressed with the work that you guys do, being able to do some home visits for these complicated patients. And I hope that, you know, this presentation was helpful for you as you provide care in the future.
I think this information will be very helpful, and we will. I think the resources through the guidelines with Sweet Success will be really useful for our home visiting population. So thank you very much for all the work that you do. And yeah, have a great day, everyone.
Thank you.
Thanks so much.